Hi friends, welcome to Classes by Lab Doctor. And in today's class, let us discuss about the diagnosis of gout. So how do we diagnose gout? So that is done with the help of the medical history, the history of any drug intake, medications, family history, clinical presentation, physical examination, lab tests, synovial fluid examination, polarized light microscopy, synovial biopsy sometimes. So all this will aid us in the diagnosis of gout. So I have told you that gout is an inflammatory arthritis. It is a crystal induced arthritis. So inflammatory arthritis are rheumatoid arthritis, psoriatic arthritis and crystal induced arthritis or the gout. So this arthritis causes a lot of inflammation in the joint. So the war between the inflammatory cells and the crystals give rise to the symptoms of gout, may it be rubor, gallor, tumor, dolor, the redness, the swelling, the increased vascularity, the fever, the chills, and the joint restricted motions. All these are because of the inflammation. So this gout is it usually involves very fewer joints, unlike osteoarthritis etc., which involve many joints. It is polyarticular. This is involving few joints. The most common joints which are involved is the metatarsophalangeal joint, 90%, the most common. This is other common joints would be the joints of the foot, the ankle, the knee joint and the elbow joint. The least common joints which are involved are the shoulder joint, the wrist joint and the fingers. So I have told you that it is an inflammatory joint because this has all symptoms of inflammation. So inflammatory arthritis are the arthritis which are caused by some infections like septic arthritis, crystal induced arthritis, immune mediated arthritis. So here you have inflammatory symptoms like the patient would be having fever, he will have morning stiffness, he will have pain, he might have swelling, he might have loss of function here. And even when you see the blood parameters also, you will have an elevated ESR, CRP, the synovial fluid would show increased WBC, all symptoms and signs of increased inflammation. So this gout, I've told you that it progresses in four stages. One is asymptomatic hyperuricemia, acute gout, intercritical gout, and chronic tophaceous gout. So here you can see the first big metatarsophalangeal joint involvement in case of gout, and you can see the redness here, increased vascularity, the prominent blood vessels here. And here this is a chronic tophaceous gout wherein the joints have been deformed here. You can see these round bumpy structures which are nothing but the deposit of monosodium urate crystals beneath the skin. The skin here is stretched somewhere. You can see even the chalky white pieces also. So the doctor, by examining the patients, by evaluating the symptoms, he will come to the diagnosis of the gout. So let us see what we see in the synovial fluid. In the synovial fluid, if it is an inflammatory arthritis, we will see that it becomes little cloudy, little yellowish. If you see the WBC count or the polymorpho-neutrophilic count, it will be around 2000 to 75,000. So there will be increased number of neutrophils in the synovial fluid. And if you see, this is the aspirate from the synovium, and here you can see that under a polarized microscope these are the needle shaped crystals which are negatively birefringent, and these are the neutrophils, abundant neutrophils you can see in the background. That is inflammatory. So these crystals are needle shaped, they are negatively birefringent under polarized light, and synovial fluid WBC count will be very high. This appears cloudy because of increased WBC. Sometimes thick, pasty or chalky joint fluid will contain large amount of crystals also. Suppose if you are suspecting some kind of an infective etiology like septic arthritis, we also need to send this for culture because that becomes the differential diagnosis. So these MSU crystals, you can often demonstrate them in the first metatarsophalangeal joints and in the knees during the intercritical period when the patient does not have any symptoms in between two attacks of gout also. When the patient is asymptomatic, you can still demonstrate these crystals in these joints. So serum uric acid level can be normal. So don't think that only if the high uric acid level is there, then only that has to be gout. So with the serum uric acid level being normal also, there can be an acute attack of gout. 24-hour urine collection for uric acid is sometimes done to assess the risk of stones for under excretion of this uric acid. So this is the gout and this is a pseudo gout. So this is a monosodium urate crystal. This is calcium pyrophosphate crystals. So these are needle shaped, these are rhomboid shaped, and this is negatively birefringent and this is positively birefringent. So pseudo gout is pyrophosphate and it is positively birefringent. See, sometimes what happens when a patient is having an unexplained joint pain, he's having fatigue, exhaustion, his blood pressure is high, his urinary symptoms have been changed, there is a swelling in the joint, there is limited range of motion in the joints, there are kidney stones, kidney dysfunction, the doctor usually asks for an uric acid test. And I've told you the uric acid in men, the normal range would be around 2.5 to 7 milligram per deciliter, whereas in female it would be up to 6 milligram per deciliter. But if at all in men, if it goes beyond 7 milligram per deciliter, we call it as hyperuricemia, and in women if it becomes more than 6 milligram per deciliter, we call it as hyperuricemia. The critical value of uric acid would be when the level of uric acid is more than 12 milligram per deciliter. So whenever we do the blood test, the uric acid level can be high. The other inflammatory markers like ESR, CRP will be raised, because these are again surrogate markers for inflammation. So uric acid, usually I've told you that it will be high, but just because the uric acid level is high doesn't mean that each person will get an attack of gout or they will end up in gout. The patients with gout might even have a normal uric acid level also. So we need to correlate with lot of other features and then come to a correlation and diagnosis of gout. So when we do the synovial biopsy, we can even see this, synovial gouty tophus. So this was a synovial from a patient with gout, and here you can see the urate crystals here, and then the chronic inflammatory cells. So whenever we are sending the sample suspected of gout, we should send it in 100% alcohol, because this tophus, microtophus, will be dissolved by formalin. So this is another granuloma. It is a chronic inflammatory reaction to this crystal, this monosodium urate crystal. So these crystals are surrounded by inflammatory cells. When it becomes a chronic affair, there will be chronic inflammatory cells like your monocytes, lymphocytes, phagocytes, giant cells, etc. You can see the amount of fibrosis, some amount of hyalinization is also there. And this is the granuloma which you can see in cases of chronic gout. Radiography also, the X-ray also shows certain changes, like you can get punched out erosion of the lytic area. There will be joint space maintained in this case of gout. So whenever you have to diagnose gout, the things which point out towards the diagnosis of gout is the involvement of the grade 2, that is the first metatarsophalangeal joint. It is a monoarticular, that is only one joint is usually involved, not multiple joints are usually not involved in gout. So that is the one joint, usually monoarticular. The uric acid will be elevated, usually the uric acid will be elevated. Patient might also have kidney problems, kidney stones, etc., like urolithiasis and the tophi. So these are key diagnostic criteria for gout. But remember, to diagnose gout, there are various criteria which are laid down, like the American College of Rheumatology, etc., which will tell you how to come to a diagnosis of gout based on certain entry criteria, sufficient criteria, and criteria to be used if sufficient criteria are not met. For example, the entry criteria is at least one episode of swelling, pain, or tenderness in a peripheral joint or a bursa. Sufficient criteria is if we are able to find out a MSU crystal in the symptomatic joints or a bursa. So if you find out that that becomes a sufficient criteria. Then there are other various criterias which will have to be qualified to call that as a gout. For example, the time course of episodes of this gout, the characteristic of the symptoms, the pattern of joint or bursa involvement, clinical evidence of tophi, their serum urate levels, synovial fluid analysis, imaging studies, the imaging evidence of gout related joint damage, all these are taken into consideration. So, remember, when we come to a diagnosis of gout, it is just not on the increased uric acid level or just because the metatarsophalangeal joint is involved. No, there are many things, like as I've told you, the laboratory features, the clinical features, the radiological features, etc. Everything has to be taken into consideration. Certain guidelines, like this American College of Rheumatology, certain guidelines for the diagnosis of the gout have to be met. Then only we can diagnose the case as gout. So these are the modalities which are used in the diagnosis of gout. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.